So whenever they define something, they always define the normal and the ab definition, right? So the definition of normal joint, normal muscle movement, sorry, let me start over. So kinesiology is the study of movement in the human being, but it's also more specifically the study of how the joints move, how the muscles move, how the fascia moves, and in fact, all the soft tissue, even the skin, the integumentary system, the nerves, and it's also the study of abnormalities of the joints and the muscles, the fascia, what kinds of conditions cause joints to be limited in their range of motion. And then it's the study of synergy of all these things, literally the synergists, the antagonists, the agonists, the synergists, how the nerves work with the muscles, how the muscles work with the bones, the tendons, the ligaments, the joint capsules, what makes things more stable, what makes things less stable. So for kinesiology, there's like a lot of joint range of motion, which is one of the first things that can be a little bit tricky because honestly, I don't think that it's meant to be tricky, but sometimes it is for some people because there's quite a few movements and you can just get overwhelmed or forget. So I'd like us to do some movement of our joints tonight. By the way, when you learn using your body, either touching or moving, that's called kinesthetic, right? When you have a kinesthetic experience, it's based in the body, it's based in touch, and that's another way of learning. Okay, so in your MBLEx folder, this is from the document Recommended Study Materials, which probably should have a name more like, kinesiology anatomy, but that's what it is for now. So let's start with the joint movements. And if you click on, before I take you through these, if you click on this link, this URL comes up from massageschoolnotes.com, joint movements, and you'll find someone's like in-depth summary on all these things with like a lot of information. And mine is just a quick summary, right? It's just a list of the movements. All right, so flexion and extension. This is flexion at the head, flexion of the neck at the head or neck flexion. This is extension of the neck, right? And this is flexion of the elbow and then extension of the elbow. Flexion of the wrist, extension of the wrist, and then flexion of the shoulder is this way, and then extension of the shoulder is that way. So in general, whenever you hear flexion, I want you to think about two bones coming closer together, right? So this is obviously two bones coming closer together. And then whenever you hear extension, think about two bones going further apart. So this is obviously two bones, actually three bones, 1, 2 with the radius and the ulna, and the humerus going further apart or opening up. So with the neck, if you look at the front of the body as let's say the jaw or the skull or the head, broadly speaking, and the vertebrae, you're bringing the head and the vertebrae together. Or you can think of each vertebrae, C1, C2, C3, C4, C5, C6, all the way down to C7 and T1 coming together. And then that's as far as the front surface goes, right? The back is actually coming apart. So why is it not flexion and extension? Well, I think probably because you have to choose one position to orient from. So this makes perfect sense. The eyes are in front, and therefore this is considered joint closing, and this is considered joints opening. So they call this extension, and they call this flexion. At some places, extension and flexion are not used, like in the ankle, for example. When you flex the foot, that's actually called plantar, like plantar surface, plantar flexion. And when you extend the foot, that's actually called dorsiflexion or dorsal flexion, right? So there's the dorsum of the foot and there's the plantar surface of the foot. So dorsal flexion and then plantar flexion. All right, so there's flexion and extension. I hope you guys are moving along with me. In the thoracic spine, it would look like closing the chest for flexion, right? We're using the front surface of the body as the reference, as the point of perspective, right? And then lifting the chest would be extension of the thoracic spine. So the thoracic spine is about here. This is the level where the flexion and the extension are occurring. So I hope you guys are doing this. Right? And then further down, for the lumbar spine, that would look like this. And I always think of flexion and extension at the lumbar spine as sitting all the way back in your chair or sitting all the way back on a bench or something like that, right? So if you sit on the edge of your chair, come to the edge of your chair, put the sit bones right on the edge, and you can feel how that tilts the pelvis forward and extends your lumbar spine, extends your low back. And then if you go all the way to the back of the chair, gee, maybe a black chair with black pants and a black shirt weren't the best choice for tonight. I apologize. If you go all the way to the back of your chair, hopefully you have a back on your chair and you're not sitting on a drum stool like I am. Then hopefully you can feel how that allows your pelvis to tuck under, right? And that flexes your lumbar spine. So this is lumbar spinal flexion, and this is lumbar spine extension. Lumbar spine flexion and lumbar spine extension. There will be some testing on that. And let's see. At the hip joint, flexion of the hip looks like this, right? And extension of the hip looks like that. This is a good time to bring up the difference between hip flexion and leg flexion. So a common way of saying flexion at both the hip and the shoulder is extension of the leg at the hip or extension of the femur at the hip, right? And then flexion of the leg at the hip, flexion of the femur at the hip, right? When they say knee flexion and extension, they generally don't say that because there's only flexion of the knee, there's only flexion, there's only extension of the knee. Quite frankly, I don't know why they have to make it so complicated. I think it's just more confusing and not very useful. You recall that at the beginning of tonight, I said flexion of the head at the neck, extension of the head at the neck, and those are correct terms. You will see them. I just want you to be, I want you to be prepared that they may say it that way. Flexion of the head at the neck versus neck flexion, it's the same thing. Extension of the head at the neck, flexion of the humerus at the shoulder, extension of the humerus at the shoulder, shoulder flexion, shoulder extension, right? Of course, if you were to say flex your arm, that would be too ambiguous, right? You need to name the joint. Shoulder flexion, knee joint, elbow joint, wrist joint. Okay.
I'm sorry, I have a question because
yes, this is the time and place for it. Go for it.
Just for me, but if you flex your, I guess, is that hip flexion if you extend your leg to the side?
If you extend it to the side, that's either going to be some kind of abduction,
Got it.
or it's going to be some kind of rotation externally.
Okay.
Why don't we just do that? Why don't we just do that now?
Okay.
So I hope you guys are moving along with me, having the full kinesthetic experience. So you're in your chairs right now, probably. So I'm just going to show you this from my chair. All right, so I want you to be able to see my foot because my foot's like the pointer, right? And I'll roll my pants leg up so that you can see the knee, right? So this is external rotation and this is internal rotation. Remember, my midline is over here. So right now, look at my knee and look at my foot. They're pointing externally away from the midline. That's external or lateral. Those are the same, external rotation, lateral rotation. And this way, the knee and the foot are pointing toward my midline. That's internal rotation, also called medial rotation. And if you look at the hip joint, hopefully you can visualize and feel that there's internal and external rotation happening at the hip. Okay, so before we move on, let's just put the leg in a few different positions, straight, flexed, extended, knee flexed and extended. So you can see and feel the different kinds of external and internal rotation. With the leg straight, right, it feels pretty obvious. Yeah, this is away from the midline, this is towards the midline. But if we bend the knee, I'll stand up so you can see. You guys at home can get away without standing up. If we bend the knee, the movement of the joint just looks a little bit different. The foot comes inward and the knee goes outward. But this bone here, the femur, is still rotating externally, right? So if you were to draw a line of the movement, it would go this way externally. And then the movement would go this way for internally, right? So it can be confusing when you see the foot pointing out and the knee pointing in. You think, oh, the foot is out. That's external rotation because, you know, I rotate externally this way, right? So this is external. No, not so. Look, you have to look at the femur, right? So internal rotation, external rotation. Now, if the leg is down at the side, this is external rotation. It's going this way. Internal rotation, right? If the leg is back behind you a little bit, maybe the knee is bent, maybe not. External rotation, internal rotation. If the leg is straight, the leg is straight or straight-ish. External rotation and internal rotation. In Chardet, this could look like with someone's leg behind them in extension, in hip extension. This could look like taking the leg out away from the midline. But it's not. It's a form of rotation. Now the shoulder. Same thing with the shoulder. So start with your arm down, right? So take a look at my elbow and my hand. Right now, this is external rotation, and this is internal rotation. So hopefully you guys can feel that. The thumb's pointing outward, away from my midline. My midline is over here. Now my thumb's pointing inward toward my midline. Now, if you think about the humerus rather than the thumb, you can clearly see and feel that there's a rotation outward, spinning outward. That's external or lateral rotation. And the other way, the rotation is spinning inward. So that's an internal or a medial rotation. External lateral rotation, internal medial rotation. Now, if you keep that movement going, like we did with the leg, and you just bend your elbow, then you can see there's an external rotation going that way and an internal rotation going this way. And this makes a little bit more sense because the hand is moving outward or inward the same way that the humerus is moving. Internal rotation and then external rotation, right? And then if you raise your arm up to 90 degrees, which sometimes you'll see in muscle tests, this is external rotation and this is internal rotation, external and internal. But what if you straighten your arm? Or what if you extend at the elbow? Can you also visualize external and internal rotation at the shoulder joint, external and internal rotation of the humerus at the shoulder joint? What if you put your arm up? Can you also visualize external rotation, internal rotation? Can you feel that? And also feel how demanding that is for the movement of the shoulder. What if you do it out at the side? Can you also feel that? The thumb's pointing backward, humerus is rotating externally. Thumb's pointing down, almost backward in my case, and humerus is rotated internally. Let's see, are there any other tricky movements for internal, external rotation for the shoulder or hip? I think that about covers it. Okay, so we'll call that good enough for internal and external rotation. So we did flexion and extension, and we did internal and external rotation. Let's go to abduction and adduction. So Chardet, this will get into the leg out to the side. So so if I move my leg away from my midline in a straight movement to the side, that's strictly speaking abduction. And I'd like you to get in the habit of saying abduct and adduct. Abduction, a deduction. Here's a silly question. Can everyone see me? Let me know if you can't see me. So a abduction and a deduction, right? And you think about the midline. My midline is right here. So I'm adducting or adding toward the midline, adding my leg toward the midline, abducting or abducting my leg away from the midline. What if you flex the hip, right? If you flex the hip, this is also abduction, abducting, and this is a deduction or adducting. But most people, if you get them to try to adduct at the hip joint, there may be some amount of internal rotation, right? So this is correct in some kind of, test. They're doing the instructions that you ask them to. And there may be a little internal rotation. Yeah, forgive them for that. So they don't get an A. That's all right. You're trying to see if they can do this, or if they have pain, to discern whether or not they have some kind of tendinopathy or tendon tear of the adductor muscles, because that will definitely be painful, crossing the midline, compressing the adductor tendons. But I digress. So away from the midline or toward the midline. Now, the foot. Recall the question that we had a few days ago about inversion versus eversion. So also consider that in those movements, or recall in those movements, that there is some amount of adduction. So I'm actually adding this surface of the foot toward the midline. And then there's abduction, abducting the foot away from the midline. So there's some adduction, adding, and some abduction, abducting, taking away, right? Now you may ask yourself, let me back up. Let me see if I can do this with the hip. You may ask yourself, if my foot is moving away from the midline, why is this not abduction? Why is this not a deduction? Well, I guess technically speaking, the foot itself is being added or abducted, but where's the movement coming from? That's what you have to consider. It's coming from the hip joint, right? I'm not actually moving from my ankle joint, from my foot joint. I'm moving from the hip joint. So this is not really a movement of abduction or adduction. It's a movement of external rotation and internal rotation. And then with the shoulder, it's the same thing, moving away. Here's the midline, moving away from the midline is abduction, moving toward the midline is adduction, right? Abduction, adduction. And it doesn't matter whether or not the elbow is flexed or extended. It doesn't matter whether there's supination or pronation or what's happening, right? It doesn't matter the position of the arm. Moving out away from the midline or toward the midline is some kind of abduction or adduction, right? So this is shoulder or humerus or humeral abduction, and then shoulder adduction. And this is called, you probably know this is also called cross flexion, this movement that you're adding toward the midline. This also is abduction. This also is adduction, right? If you start here, then you would abduct and then you would adduct. This would be a good time to take a look at this site, which is in your recommended study materials. No. Here we go. So this is the ACE Fitness, one of the guides that they have for personal trainers. I'm actually studying to get my certification as an ACE personal trainer. So you guys won't be the only ones taking a standardized test soon. And you can see nice drawings. And here's adduction and abduction. And there's one that I want you guys to really look at. Here we go. So here's abduction and adduction, and look at the movement that's being done. So it makes sense. There's adduction, right? Here's the midline. So the arm is being adducted to the midline. And then there's abduction, the arm's being abducted away from the midline, right? So this is a lot like, what movement is this like? It's kind of like a golf swing, right? Something like that. Or maybe maybe using a scythe to whack the weeds, right? And then the other motion is like this, right? So they like to be really specific. Kinesiologists and anyone who uses kinesiology, like physical therapists and massage therapists and acupuncturists, they sometimes like to get really specific. This is not just abduction, it's horizontal abduction, right? And then horizontal adduction. And they're calling this abduction and adduction. Abduction and adduction, horizontal abduction, horizontal adduction. So I think it's important to be specific sometimes, especially when you're charting or making notes or trying to remember things, that you be specific about where the humerus is, since this is a multi-planar joint, ball and socket joint that moves through many planes. I think it's important to be as specific as you can so that when you look at your notes, that you discern where the arm is starting from, right? Because pain in this direction, in this plane, is going to indicate different structures, the muscles in the back or the front of the shoulder, compared to pain in this direction, which might be more indicative of like supraspinatus pain or a bursa that's underneath the deltoid, something of that nature. Something of that nature on the side of the shoulder, that is. Okay, and we'll look at this website a little bit later because it does talk about one thing that I found interesting is that when they give the names of the movements, they also indicate which muscles perform the movement, which is handy, right? And some of these things are not always so intuitive. Like internal shoulder rotation, for example, you might know that it's the subscapularis that does internal shoulder rotation, right? Which is like this. And everybody do this with me right now. So the elbow is inside and the arm is outside. So this is the subscapularis test or subscapularis stretch. You probably have seen people do this kind of like cactus-y type stretch. I'm stretching the arm with the tattoos, the stripe tattoo on it right now, right? And I'm pulling my arm this way using a hand as a lever, and that's stretching the subscapularis muscle. So also the latissimus dorsi and the pectoralis major, maybe not quite so intuitive, but they are involved in that internal rotation of the subscapularis. So what else do I want you to know about that? Yeah, I think that's good for now. And we'll get into the attachments of muscles like these a little bit later. It is a lot of information once we start to talk about where muscles originate and insert, or where they attach. But if you can start to integrate it little by little on a daily basis, it'll really help you understand which way it moves the bones, because that is what kinesiology is. That's one of the cornerstones of kinesiology, or one of the cornerstones of massage therapy or body work or acupuncture, is understanding what muscles and what tendons might be involved by having the person say, oh, it hurts when I do this, right? Or when I do that, you know, or having them say it's painful when I do this, you know, and understanding what muscles are involved in those movements. The joint ranges of motion. Okay, so we've done flexion and extension, abduction and adduction, and then we did internal and external rotation. Medial and lateral rotation are the same as internal and external rotation. Medial and internal are the same. Lateral and external are the same. Medial, internal. So medial, internal rotation, lateral, external rotation. Okay, before we do elevation and depression, which is specific for the shoulder blades, let's do supination and pronation. So I remember supination like carrying a bowl of soup, and pronation like prone to spill it. And you guys probably have heard that a million times. I just learned that like last year, but I just had to always remember this is supine, face up is supine, palm up is supine, palm down is prone. And we don't say internal and external, I'm sorry, we don't say external rotation of the wrist or elbow internal rotation of the wrist or elbow, even though we have a bone called the radius and its purpose is to radiate the thumb outward, radiate the thumb inward, we say supination and pronation, right? So that is something that you'll run up against. And I believe that where ankle sprains are concerned, where internal and external movements of the ankle is concerned, yeah, that there's also pronation and supination. The terms are pronation and supination. Yeah. So here's without all the other three movements, the flexion, extension, and all that. Now they're showing supination here and then pronation over here, right? So it's a little less obvious with the foot because with the hand, you clearly get the bowl of soup like that, like this, how you carry a bowl of soup, right? With the foot, not so much, but imagine the surface of the foot moving towards plantar surface up, right? And that's considered to be supination. And then pronation is not just the plantar surface facing down, it's the plantar surface facing down with the pinky toes turning up, right? Please do this with me. So this is pronation with the plantar surface turning up, and then supination with the lateral or the pinky side plantar surface turning up and big toe surface turning down. You can also imagine it around an axis, right? Draw a center axis through the foot all the way back through the heel, and you turn medially, so the surface of the foot is going toward the midline in supination. When you turn laterally, the surface of the foot is going away from the midline in pronation. Oh yeah, abduction and adduction of the ankle. Yeah, so AB, abducting, is away from the midline, and adducting, this is towards the midline. You could use like the big toe and draw an axis down the center of the tibia, and taking the toes out away, seeing which way the big toe is pointing is abduction. Looking at the movement of the big toe and the other toes toward the midline is adduction. Can I get some feedback here on my delivery of the terms so far? How am I doing? Is it like confusing? Am I adding too much additional? I'm concerned that I'm adding too many additional terms.
Not for me.
Okay. Do you guys feel a little bit like anyone feeling a little bit overwhelmed?
No, I get everything. Everything's pretty clear.
Okay. 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 So in other words, I'm not the only one who's a little off. Okay, so I got to work on my delivery. Okay, so internal rotation, yeah, supination and pronation, inversion versus eversion. Okay, let's go back to that foot. So inversion, yeah, this is inversion. That's where the big toe side picks up. That also has a lot of supination in it. And then eversion, let's see if there's another eversion. Eversion is where the pinky toe side picks up. There's pronation in that one. So three movements in inversion, right? There's supination. There's also adduction, so the foot is swinging toward the midline. And then there's some plantar flexion. The foot is going downward. We did this, I think, like the first class, maybe. So that would be some flexion. Sorry, some plantar flexion, because it's plantar flexion and dorsiflexion. We do some flexion, right? And then we do some supination, and then some adduction adding toward the midline. So there's and you can do it any order you want. So there's adduction, supination, and then flexion, right? Or supination, flexion, adduction. And then the other way would be pronation, and then extension, and then what's the one that I'm missing? I'm sorry, dorsiflexion, not extension, dorsiflexion, and then abduction. Abduction, dorsiflexion, and then pronation. Yeah, so my recommendation is that you make a note of which of these movements are kind of tricky. Like the inversion and eversion of the ankle is definitely tricky because you basically have to have 6 movements down, right? And then you have to know inversion and eversion. Those are just summaries of 3 movements one way and 3 movements the other way. Okay.
I will say that I'm a visual learner more, like the visual helps stick to the wording. So I appreciate all the movement that you're doing.
Yes, yes. Can you discern a difference in moving your own body when you're doing that? Does it make it
Yeah,
stick a little bit?
absolutely. Every
Good.
time you do it, I do it too. So it helps me remember which way is, or which definition is which.
Fantastic. Good. Okay. We did dorsiflexion and plantar flexion, wrist deviation, ulnar deviation. So wrist radial deviation. So here's the radius, the radial side. So this is radial deviation. Here's the ulna. So this is ulnar deviation, right? And you can turn your palm toward you, and these bones will turn as well. Maybe I should do it this way. Yeah. So this is the radius, and this is the ulna. Yep. So radial deviation, and then ulnar deviation. Radial, ulnar, radial, ulnar, radial, ulnar. Looks like playing the piano, right? Ah, yeah. Radial deviation is also a form of abduction. So even if the thumb is moving toward the midline, that's also a form of abduction, because the anatomically correct position would be supination, right? So radial deviation this way, and then ulnar deviation this way. Adduction, abduction, adduction, abduction. Tricky, right? Because if you're looking at it this way, of course, this seems like adduction. But the movement itself, being radial deviation, is looked at from the perspective of someone looking at the palm. So if you look at the palm, it's actually moving this way, away from the midline. The anatomical. You guys know the anatomically correct position is with the palm up and the elbows extended and the humerus down at neutral, correct? Good.
Yes.
Awesome. Okay, now the shoulder blades. So this is best visualized with no shirt, with a tank top, or with a white shirt. But you guys just move your shoulder blades and you'll feel it. So elevation versus depression. So when you have elevation of the shoulder blades are moving up, shrugging the shoulder. When you have depression of the shoulder blades are actually being pulled down by the latissimus dorsi muscles being contracted. And those are antagonists. The latissimus dorsi and the upper traps are antagonists. So upper traps elevate, latissimus dorsi depress. And then for protraction and retraction, which are my 2 personal favorite movements of like almost the whole body, because they affect our posture and they affect our arm strength and our breathing. They affect everything so much. So for protraction, the shoulder blades are moving all the way apart from each other. And for retraction, they're squeezing together, trying to create that pinch in between the shoulder blades. Right? If you put your arms up this way, by the way, what movement did I do in order to accomplish my arms being up like this? What movement at the shoulder joint, what movement of the humerus at the shoulder joint did I do to get my arms in this position?
Extension.
Flexion.
Extension is this way. Yeah, flexion. That's correct.
Yeah, I meant
So
flexion.
It's okay for you to mix them up here, but on the exam, make sure that you say flexion for flexion and extension for extension, obviously. So if you hold your arms up in flexion and you extend your wrists, the movement becomes like a push or a push-up, right? And then you can really feel how protracting the shoulder blades helps you to reach your arms forward, helps you to get some extra reach. And retracting the shoulder blades can help you pull the arms and the hands backwards, right? So protraction, retraction, protraction, and retraction. Let's see, is protraction and retraction used anywhere else in the body? Protraction, retraction, body. Yeah, there's the shoulder blades. Where does protraction come? Serratus. Okay. Oh, this is always useful. Don't worry, we're not going to spend a long time surfing the web tonight. It's not going to be like last time. So protraction, the shoulder blades coming out away from each other, pushing, right? Protraction, pushing, is accomplished by the serratus anterior, the pectoralis major, pectoralis minor muscles. So while we're here on the subject, please place your hand on your serratus anterior. If you don't know where that is, find the midline of your side. I call it the side line or the lateral line, and get to about the level of the tip of your shoulder blade with your arm flexed at 90 degrees, with your humerus flexed at 90 degrees. Find the tip of the shoulder blade and come forward to your side line. And right under your fingers, your serratus anterior muscle should pop out a little bit as you start to protract your shoulder blades. It also helps to depress your shoulder blade a little bit, but if you reach your arm forward, you should feel some kind of like small wispy, because they're underdeveloped on most people, serratus anterior muscles. It's in front of the latissimus dorsi. So you might be feeling this. See how my fingers are being pushed out right there by my lat? If you feel that much movement, that's not the serratus, that's the lat. Serratus is just in front of that. Here, I'll move my hand a little bit more. And you can feel the serratus a little bit more as you start to push your shoulder blades forward. If you can't feel a muscle that's like thinner, like the serratus or the rhomboids, if you can't feel a muscle like that on your own body, that just means that it's inactive. It's not working. It's just not working as much as it could, right? And also, if you're not used to doing pushing exercises, if you're not used to doing protraction with some resistance, then those muscles are probably not developed to the point where it's easy to feel them, but you should be able to feel some firing of the fibers in there. Okay, and then pectoralis and pectoralis major and minor, right? If you place your hand on your pectoralis major and then place your fingers up under the clavicle and find your pec minor, you should be able to feel those like pretty clearly, right? And which one is firing when? Well, yeah, we won't go into that too much today. And then retraction is accomplished by the trapezius, the rhomboids, and the latissimus dorsi. Well, the trapezius, that one should be fairly obvious. It's the mid traps, not the upper traps, but the mid traps that pull the shoulder blades together. And then also the latissimus dorsi, those muscles have fibers that wrap around, grab the lower angle of the scapula, and then attach to the thoracic spine. And then what else? And then the rhomboids. Yeah, the rhomboids. That one should be obvious. Okay. So that's all for what I consider to be like the basic joint movements. Let's look at some movements that I consider to be a little bit more specific, a little bit beyond basic. So lateral flexion, I list here that it's the neck and the spine. It definitely is the neck, right? So this is lateral flexion of the head at the neck, or lateral neck flexion or neck lateral flexion, right? It also happens in the thoracic spine, right? So right now my mid back is flexing. I can feel it right through here. Right? Go easy. Don't be too aggressive with these if you're cold or not warmed up, right? So this is lateral flexion of the thoracic spine. Be really careful with this one. This is lateral flexion of the lumbar spine. So it's right here that I'm achieving lateral flexion. The right side of the vertebral column is opening. Now the left side of the vertebral column is opening and the right side is closing. And the lateral flexion will become important later when we discuss which muscles do lateral flexion on the same side, which ones do lateral flexion on the opposite side. Rotation. I don't think that we covered rotation at the spine. So let's just do it. Let's just do it now, right? This is rotation. Hopefully that's like pretty obvious to you, right? But also have the kinesthetic experience of how your spine moves when you rotate. You're rotating through the lumbar spine and the thoracic spine. And then if you turn your head, you're also rotating at the cervical spine. Okay. Horizontal abduction and horizontal adduction. We did that one a minute ago. So horizontal abduction, horizontal adduction. Oh yeah, diagonal abduction, diagonal adduction. You can do this with the shoulder or with the hip joint. So diagonal abduction and then diagonal adduction, diagonal abduction, diagonal adduction, and then remember, this is abduction and adduction. So this would be diagonal abduction, diagonal adduction, diagonal abduction, diagonal adduction. Let me do a smaller movement so you guys can see that, right? So diagonal abduction, diagonal adduction, abduction, adduction. My feet don't have to cross the midline for it to be adduction, right? This is diagonal adduction, diagonal adduction, diagonal abduction, adduction, abduction. Okay. Circumduction. Circumduction is a combination of abduction and also adduction. So draw a circle, right? And the 3 o'clock and the 9 o'clock or 9 and 3 positions are abduction and adduction. And then the 12 o'clock and the 6 o'clock positions are flexion and extension. And then there's also rotation occurring. So supination and pronation at the shoulder, internal and external rotation at the shoulder, right? So that would be adduction, flexion, there's external rotation, adduction and flexion, right? And then internal rotation at the shoulder as I start to abduct and extend, right? Adduction, flexion, external rotation, and then more flexion and then extension, internal rotation, extension, coming back down to adduct the arm. And you can do the same at any joint that allows it, including the wrist joint, right? And you can do that at the ankle. You can do that at the hip joint. You can do it at the neck, spine, whole spine allows for it. Follows a cone-shaped path of movement. So a cone looks like this. So this is the tip of the cone, and this is the big circle of the base of the cone. Right? So I'm drawing this big circle with my fingertips, and the tip of the cone is up here. Right now I'm drawing a big circle with my hand, and the tip of the cone is right here. Right? Circumduction. Same thing with the hip. I guess I got to show you with the hip, right? Circumduction. And then with the head, we'd be drawing with the neck or the spine. We'd be drawing the big circle with the tip of the head, right? And yeah, we'd be drawing the big circle with the top of the head, and the tip of the cone would be down into the spine. All right. Everybody turn on your cameras. Yes. All right. So, and turn on your mics. And everybody go like this. What movements are these?
Supination, pronation.
Supination and
Supination.
pronation, yeah. And now go like this. What movements are those? Call out.
This adduction, abduction.
Okay, and now go like this.
Circumduction.
What movement is that? Circumduction, that's right. Okay, now like this. Josh, go like this. What movements are those? Everybody go like this. And Josh, tell me which movements are those? I don't know if I can hear you, Josh. Okay, Josh, you're off the hook. Larissa, I'm sorry, Charday.
Is it protraction and retraction?
That's right, yeah. And Larissa, which movements are these? Everybody move. I can't be the only one moving here. The union says, you guys have to fund my healthcare fund if I do more work than you. No, I don't know. What is that?
Help me out. I know I'm on the right track.
Yes, you are, absolutely.
Down is depress
That's right.
and damn, I know it.
What do
Yes, you
you
do.
ride that goes up? Like in a
The
hotel,
opposite of
you go up.
the opposite of going down is
Jesus, I know it.
this is good. You're
Abduction,
starting to
right.
you're starting to get flustered. This is good for you to learn to think like this.
Depress and damn it, I can't think right now. Elevation.
Elevation. That's right. That's right.
Oh.
She's like, oh, it's so simple. Elevation. That's right. Yes, good. Don't forget, Larissa, Charday is not going to be there for you at the test, like talking about hotels and stuff. Okay? But you would have totally got that. You would have figured that out because you got depression. You said depress or depressed instead of depression, which is fine. That's more than enough of the term to have nailed it.
Yeah.
And then one of the choices would have been elevation, if that, if they were comparing the two, and I think that you would have seen the contrast. Yeah, no problem. Okay, now, okay, femur. Everybody touch your femur so you know where it is. Everybody touch your femur, right? Good. So now that you touched your femur, which way am I rotating?
Externally rotating.
Okay, Josh, is your mic fixed? Ah, there you go. All right, which way am I rotating now, Josh? This is external. This is which way? I don't think your mic is quite working, Josh. All right, that's okay. External, and external is also the same as what? Lateral or medial? Everybody.
Lateral.
Lateral.
And internal is the same as lateral or medial?
Medial.
Right, yeah, and do these movements with me. Okay, so now what movement am I doing at the hip joint? The movement of the femur at the hip joint. What movement is that?
Flexion.
Flexion. Yeah, that's right. So now I'm doing flexion at the hip joint. And which way am I rotating the femur?
Lateral.
That's right. Draw an arrow with the movement of the bone.
Yeah.
Is it
So
going
that
toward
is
or away
lateral.
from
That
you?
is lateral then, right?
That's lateral or external.
okay.
That's right.
Okay.
Now draw a movement with the movement. Draw an arrow with the movement of the bone. That's which way?
Medial.
Medial.
Medial. That's right. Medial is also called what? Internal or external?
Internal.
Internal.
Internal. That's right. That's right. Okay. Here's a trick question. Show me the medial rotation of the spine at any point in the spine.
The medial rotation.
You can't do it.
Yeah.
The spine is not said to move that way. The spine itself is on the midline. Medial rotation occurs toward the midline.
Yeah.
Toward the midline. Lateral rotation occurs away from the midline. Okay, show me supination of the neck, supination of the head at the neck. Second and last trick question.
Wait, no, that's not supination, right?
No, it's not supination. There's no such thing as supination
Yeah.
of the head at the neck. Very good. It would be 2 or 3 different movements. Let's break them down. So if I were to supinate the head at the neck like this, what movements would those be? I'm feeling one this way. I'm feeling one this way. I'm feeling a little bit this way. So what 3 movements are those?
One is
So
flexion. Yeah.
what kind of flexion? This kind of flexion?
Lateral.
Lateral flexion. That's right. Also called side flexion, lateral flexion. Right. And then one is this way. Which way is that?
Extension.
Extension. Yes. Yes. Someone who's not Marcos.
I'm sorry.
Now, how about this way? How about this way? Which way is that?
Rotation.
Rotation. That's right. So rotation, side flexion, extension. Everybody do those one at a time so you can feel them. Do it to the other side if you've done it already. Rotation, right? Drop your ear down toward your armpit. That's side flexion. And then bring your nose a little bit higher up. That's extension. Feel how your neck extends. Okay, come back to neutral. Let's break them down one last time in opposite direction, opposite order. So extension, right? And then let's do rotation, right? And then side flexion. Okie doke. Orientation terms. Distal and proximal. Distal aspect of the upper limb, proximal aspect of the upper limb. Distal aspect of the lower limb, proximal aspect of the lower limb. Upper limb, lower limb. Proximal, distal, proximal, distal. For the upper arm, upper limb. For the upper arm, proximal, distal, proximal, and distal. For the wrist, proximal and distal. Well, this is not the wrist. The wrist is this much, that much. So for the hand and wrist, proximal and distal. Then for the finger, notice there are 3 bones here, proximal and distal. And then the one in between is the intermediate, proximal and distal. For the lower body, for the upper leg, lower limb, upper leg, proximal and distal. For the lower leg, proximal and distal. And then for the foot, proximal and distal. And then the same thing for the toes. You'll never, toes are too small to be seen on camera, but for the toes, it would be the same thing. It would be proximal and then distal, right? Proximal interphalangeal joint, distal interphalangeal joint. We should go over some of those bone moves. Right, we get done with the orientation stuff. So medial and lateral, we've already seen regarding the humerus, medial rotation and lateral rotation. Medial means toward the midline, right? So right now the arm is moving medially. Right now the arm is moving laterally. Move your arms laterally, move your arms medially. Move your leg laterally, move your leg medially, right? It's also abduction, adduction. It's also supination and pronation, internal and external, medial and lateral, internal and external, medial and lateral. You also could say, like, for example, I feel like my neck is deviated, my head is deviated laterally from the midline. Okay, so move it a little bit more medial. See if you can do that. Lateral deviation from the midline, move it a little more medially, right? Or if someone is saying, where is the midpoint of the clavicle? Is it here? You could say, no, it's a little bit more medial that way. Or where are you having pain? I have pain between the ribs, right about here. No, you're palpating on your patient and your patient is going a little bit more To the side, which side? The inside or the outside? Well, lateral is clear, medial is clear, to the side is not so clear. I remember one time I was meeting friends they're from Italy, and I went to the joint and they left a note. Kim, we're up the street. Join us. This is a two-way street. I'm like, I went up and down the block. I was like, I never let them forget that story. Okay. Now, anterior and posterior. I don't think this one is too tricky. Anterior is the front, posterior is the back. Anterior is the front, posterior is the back. I would say that the leg is pretty straightforward, anterior and posterior. The forearm, because there's some rotation that happens at the elbow, could be a little tricky, but remember that this is the anatomically correct position. This is where you always start. This is where neutral or zero angle is considered, right? So this would be anterior, this would be posterior. So the flexors, the wrist flexors would be anterior surface. The wrist extensors would be the posterior surface. Biceps would be the anterior surface. The triceps would be the posterior surface. I seriously doubt you're gonna see it that way on the test. Like, where's the anterior surface of which muscles on the anterior surface of the arm? But it's helpful to think about it that way, just so that you kind of strengthen your knowledge base. Superior and inferior, again, these are relative, just like proximal and distal. So superior is up here, inferior is down here. I would also like you to think of superior as caudal. Caudal means towards the head, or coronal means towards the crown, toward the corona. Coronal, caudal, superior. So sorry. Coronal is superior. Caudal means footward, toward the foot. So inferior, the foot is inferior. Caudal is inferior to coronal. Coronal is superior to caudal. Superior, inferior, superior, inferior, superior, inferior. I generally don't think of the limbs as having points on them that are superior or inferior, but you could see it that way. In general, I would relate to them more as proximal and distal, proximal and distal. Do you guys want to practice some of those, doing some like self-touch, or are you good for now?
Me personally, I would like to practice.
You want to? Okay. So distal and proximal. So let's do the hand, because that one's pretty tricky. Okay, so this is distal and this is proximal. And what we're looking at are three bones, 1, 2, and 3. Right? So distal, proximal, and distal. And this one is the interphalangeal, or the intermediate. Proximal, intermediate, and distal. Next one, proximal, intermediate, and distal. Repetition is the mother of learning. Proximal, intermediate, and distal. Proximal, intermediate, and distal. The thumb has only 2 bones, one proximal and one distal. Proximal phalange, distal phalange. This bone here, what is that called? Should look that up. This bone is proximal to this bone. Let's look that up right now. Bones of the thumb. I'm glad I ain't taking this exam. Did I say that or think it? That is a metacarpal bone. So this bone, let me show you on the screen first. Okay, this is a metacarpal, just like these other 4 metacarpals, right? Index, middle finger, ring finger, pinky finger, metacarpals, and then carpals. So the carpals are in here. The metacarpals are the longer bones in front of the short carpals, the longer bones here, right? That's kind of like where the tendons start to pop out, and they're like, which way, proximal or distal in relationship to the knuckles? Here's the knuckle, here's the metacarpal. Are these proximal or distal to the knuckle?
Oh, that was a question. What
Yes.
was the question again? I thought you were
Are
still.
Are the metacarpals, are they in relationship to the knuckles? Are they proximal or distal? The metacarpals in relationship to the knuckles.
They are proximal.
That's correct. Proximal is toward the tip. Distal is towards the tip. Proximal is toward the center of the body, right? And are the knuckles proximal or distal relative to the phalanges? Proximal or distal relative to the phalanges?
Distal.
Phalanges. Knuckles, phalanges. Proximal or distal? Knuckles, phalanges.
Oh,
Are
they're
those proximal or distal? They're proximal. They're toward the center of the body. And are the knuckles proximal or distal relative to the wrist?
You said are the knuckles?
Are the knuckles proximal or distal relative to the wrist?
Oh, they're distal.
They're distal to the wrist. That's right. Yes. Would anyone else like to have a go at proximal and distal? Okay. Josh, you want to try? Was that a hand? No. Okay. Oh, Josh, I hope you can fix your audio. It would be nice to fully interact with you. Okay. Yeah. So back to what bone is this? This is a metacarpal. Metacarpal. It's
The one
carp-
that I was having is, oh, I'm sorry, go ahead.
No, go ahead.
The one that I was having trouble with is the superior and inferior, like regarding
Superior and inferior.
the whole
Yeah.
body.
Okay, so it's all relative, right? Superior is toward the top, inferior is toward the bottom. So we already did superior and inferior, right? And then this would be superior. The chest is superior relative to the abdomen. The abdomen is superior relative to the pelvis.
Okay.
So place your hand on your abdomen, for example. Is the sternum superior or inferior to the belly button? Is the superior or inferior?
Superior.
Superior, right. And is your femur superior or inferior to your chest? Femur, chest.
Is inferior.
It's inferior. That's right. And what about your medial malleolus? Is that superior or inferior to your knee?
Inferior.
Inferior to the knee. And is it superior or inferior to your navicular bone? Or any of the tarsals? Tarsals are in here.
Yeah.
Superior,
It's
inferior.
superior.
That's right. It's superior. It's superior. And is it proximal or distal to these bones? Is it proximal or distal to the carpals, tarsals? Is it toward the center of the body or away from the center of the body?
It's towards, so it will be proximal.
Yes, exactly. Exactly.
Let me write that down.
Mm. Okay. Let's look at a few of the like trickier joint names. When you combine two bones, sometimes it can sound a little strange at first, but it should be pretty intuitive actually, right? So the shoulder joint is also called the glenohumeral joint. So the cup of the shoulder is the glenoid fossa. Fossa means whole. Glenoid, thank you, autocorrect. Glenoid fossa. And the glenohumeral or humeral, O-L-A-L, humeral joint is another name for the shoulder. Now, you may find it spelled like two words, or you may find it spelled like one word. It just depends on who's doing the spelling. What's important is that you see both of those words in there. That's the glenoid, that's the humerus in the glenoid fossa. The hip also has a similar name. So with the hip joint, the whole, the fossa is called the acetabulum. And the bone down there is the femur. So it's the femoroacetabular joint. That's the femur in the acetabulum. Then for the hand, you have carpals, and then you have meta, like derived from or somewhat like metacarpals, right? And then you have phalanges, and then you have interphalangeal joints. Interphalangeal joints. And then you also have metacarpal phalangeal joints. Okay, so find the carpals, find the phalanges. Phalanges. Let me give you one phalange so it's clearer. Phalange, carpal, phalange, metacarpal, carpal, carpal, metacarpal, phalange. Repeat and touch.
Phalange, metacarpal,
metacarpal, and carpal.
carp,
Carpal, metacarpal, and
metacarpal
phalange.
phalanges.
Right. This is the metacarpal phalangeal joint. Metacarpal phalangeal joint. Carpal metacarpal joint. Carpal metacarpal joint. Metacarpal phalangeal joint. And then these are the two phalanges. So this is an interphalangeal joint. And these are two phalanges. So this is an interphalangeal joint. How do you distinguish between this interphalangeal joint and this interphalangeal joint? This one is the proximal interphalangeal joint. This is the distal interphalangeal joint. Proximal interphalangeal joint, distal interphalangeal. Let's go all the way up. Distal interphalangeal joint. Repeat after me. Distal interphalangeal joint.
Interphalangeal joint.
Yeah. Let's try it this way. So your hand's in a different position. You have to really think. Distal interphalangeal joint. Proximal interphalangeal joint.
Distal proximal.
Good. Metacarpal phalangeal joint. Carpal metacarpal joint. Turn your thumb up. Radiocarpal joint. Ulnar carpal joint. Radiohumeral joint. Ulnohumeral joint. Radio-ulnar joint. Glenohumeral joint. Humerus and glenoid fossa. Glenohumeral joint. Scapula and clavicle. SC joint. Scapuloclavicular joint. SC joint. Scapuloclavicular joint. SC, wait, I always have to look that one up. Do you guys know the name of this joint between the clavicle and the manubrium? Joint, clavicle and sternum. The sternoclavicular SC joint and the joint between the clavicle and the scapula is the acromioclavicular joint. Damn, I'm glad I looked that up. I would have messed that up. Wow. Food for this? What? I should be signed. Okay, acromioclavicular joint, sternoclavicular joint, acromioclavicular or AC joint, and sternoclavicular or SC joint. Wow, I need practice now. Okay, sternoclavicular joint, SC joint. Sternoclavicular joint, SC joint, sternoclavicular joint, SC joint, acromioclavicular joint, acromioclavicular joint, acromioclavicular joint, glenohumeral joint, radiohumeral joint, ulnohumeral joint. Let's go back up into the chain. Here's one you may or may not have heard of. This is the scapulothoracic joint, scapulothoracic joint. Right?
Mm.
Thoracic joints, cervical joints. Let's look at the joints of the skull, and then take a break, and then we'll do some quizzing. Okay. Wow, man, look at all these joints. Let's look for a simplified version. Okay. Amboss. Amboss. Okay, so oh, they're gonna make me scroll through all this stuff. No way. No. Okay, I'm gonna get up on the break. I'm gonna get those up, so you don't have to spend time like looking at those now, because I have some other drawings which are nicer and more accessible. So let's take a break. 10-minute break. Come back at 7:25. Okay.
All right.
See you guys in a bit. We're resuming the recording. Okay, quickly, let's look at the bones of the skull and the joints of the skull and like the upper neck. We won't spend a lot of time on this because we don't have a lot of time. So frontal bone, parietal bone, occipital bone. This is the temporal bone. Temporal bone. Temporal bone. Notice that the mastoid process, oh, I'm sorry, I'm disoriented. This is the mastoid process, and this I believe is called the styloid. Mastoid process and this styloid are part of the temporal bone. Here's the zygomatic arch, which is part of both the temporal bone and the zygomatic bone. Temporal bone, zygomatic bone, zygomatic. Sphenoid bone, here's the label up here. Sphenoid bone. Nasal bone, maxilla. I almost said frontal bone. Frontal bone, maxilla, mandible. Okay. The newborn illustration is useful because it's the only one in the book that shows the skull from above. So this is the frontal bone, parietal bones, occipital bone, posterior and anterior fontanelles, and these are the sutures. These joints later, I forget what they're called. We'll look at them next time. The coronal suture, the sagittal suture named after the plane, the lambdoid suture because of the shape of it. Parietal bone, frontal bone, nasal bone, maxilla, zygomatic bone or zygoma, zygomatic arch, temporal bone, sphenoid bone, occipital bone, and parietal bone. Parietal. Okay, joints of the skull. You know, if you wanted to, you could really go crazy with all these joints, but the major ones I know for sure you're going to need to know are the temporomandibular joint. You've heard of TMJ, temporomandibular joint, right? So here's the temple area. Here's the temple area. Recall that all that's called the temporal bone, right? And the joint with the mandible is right here. Here's the mandible, here's the temporal bone. Temporomandibular joint. It has a capsule, it has ligaments, has a nerve supply, has everything. It has a meniscus or two, just like any other joint. Okay, the atlas and the axis. Somebody unmute him or her or themselves. Tell me, what do you think the joint between the axis and the atlas is going to be called? The atlas and the axis. That's going to be called the atlantoaxial joint. Atlantoaxial joint. Okay, and what about the joint between? What about the joint between the atlas and the skull, or the atlas and the occiput? That would be the atlanto-occipital joint. The atlanto-occipital joint. And then there's one or two more joints I want you to see, and then we'll move on. So just remember these names, or have heard the name. Zygopophyseal joint. I believe that's named after the shape of the lateral body of the vertebra. And I think that's about as far as we need to go. Atlanto-occipital membrane, atlanto-occipital joint, atlantoaxial joint. Let's get oriented to the parts of the vertebrae while we're here. So on the sides of the vertebrae, we see the transverse processes. The transverse processes. In the center, that's the body of the vertebra, the body of the vertebrae. On the posterior aspect of the spine, so this is the back of the neck. If you touch back here, these are what you're touching. Those are the spinous processes. You feel them all the way down and all the way down the spine. Spinous processes are in the front. Yeah, note until further discussion that a facet is a kind of a divot, kind of a very shallow, like a saucer, and they fit together to make facet joints. So this is actually a facet joint. These are the zygopophyseal joints. They're a type of facet. The ribs articulate. Here, costal facet for the first rib. The ribs articulate with these facet joints here on T1. I think each vertebrae has like 3 facet joints. Okay, so that's enough for, that was Frank Netter, by the way, N-E-T-T-E-R, one of my favorite anatomists. Okay, so let's take a look at some of the questions now. Let's start with this kinesiology 10 questions from the ANTA app. So I'd like to zoom in. Okay, which of the following options best describes active stretching? This is not, we didn't cover this, but it is kinesiology, it's important. That would be moving a client's joints through full extension and flexion. When a second person applies the force to stretch someone else, when a person stretches themselves, the active contraction of the agonist to the muscle being stretched, which best describes active stretching. And the answer that they pick is when a person stretches themselves. Okay. A client reports pain in her neck when she looks up at the sky. Which movement term describes the motion? Looking up at the sky. Neck flexion, neck extension, neck rotation, or neck lateral flexion. And that, I hope you would know, would be extension. Okay, a pitcher is recovering from a shoulder surgery and is working to improve stability in her shoulder. She performs the following exercise. She stands next to a wall. Let's say the wall is here, and pushes her wrist into the wall, creating external rotation. So this is abduction, not external rotation. External rotation looks like this. So it's going to be more like this, maybe even more like that. External rotation in the shoulder. No movement occurs, but shoulder muscles are still contracting. What type of contraction is this, and which muscle is the prime mover? For external rotation, that would be the it's the infraspinatus muscle, so it's one of these two, and not moving would be isometric. My son is reclaiming his domain. Can you bring my coffee out, please? And he does not want to appear on camera. I can assure you he is quite good looking and smart. Not as strong as his old man. But anyway, all right. Come over here, Max. Come over here, Max. Come here. Okay. How do we get the next one? Come here, Max. Come here. Come here. Yes, we're on camera. While slowly performing controlled ankle dorsiflexion, which muscle is eccentrically working? Okay, we didn't talk about eccentric, concentric. So the way I think about eccentric, concentric is that con is with or contracting, right? So right now, so for dorsiflexion, the contraction is happening in the front, in the tibialis anterior muscle, right? So this is contraction, and this is not contraction. This is contraction back here. So this is concentric in dorsiflexion. This is eccentric in plantar flexion. This is concentric in plantar flexion. This is eccentric in dorsiflexion. Okay, so ankle dorsiflexion. When you take the test, I want you to say things twice so you really get them clear in your, so you can picture it in your mind. Controlled ankle dorsiflexion, dorsiflexion. Which muscle is eccentrically working? Ankle dorsiflexion, eccentrically working. That's got to be the soleus, not the extensor hallucis longus, not the gracilis, not the tibialis anterior. Those are not on the correct surfaces. Soleus. Raise your hand if you don't know where the soleus muscle is. Shardy and Josh, it's not too late to come back and go like this if you want to know the soleus. Okay, during the
I'm
muscle
sorry.
contraction.
I too have a child, so he's here trying to correct his homework while I'm doing this.
Oh my God, super mom, respect. Soleus muscle. So the soleus is in the back of the foot. Yeah, okay. Here's a decent one. Is this a decent one? No, here's a better one.
Hey, Kim,
So
I'm sorry.
this is-
I'm sorry, can you show me what eccentric and concentric is again? Concentric is when it's,
Yes. So concentric is when the contraction moves with the direction of the joint. Or
okay,
concentric is the muscle that contracts with, like con, right? So this muscle contracts with the movement, in this case, dorsiflexion.
right.
So it's the tibialis anterior, the one in the front, it's
Mhm.
contracting.
Mhm.
Now, if I plantar flex, it's the one in the back that's contracting with plantar
Mhm.
flexion, right? So this would be concentric with plantar flexion.
Okay.
Plantar flexion, this is concentric. Plantar flexion, the tibialis anterior is eccentric. Okay, now your turn. Now your turn. For dorsiflexion, which one is concentric? The one in the front or the one in the back? Front or back?
What's concentric? It will be the one in the front, right?
The one in the front. What's the name of that muscle?
Tibialis anterior.
Yep. And which one is eccentric? The one in the front or the one in the back?
It'll be soleus.
That'd be the soleus, yes,
Soleus,
or the
okay.
gastrocnemius, yes.
Okay, great.
Soleus or the gastrocnemius, yeah. One more. So with wrist extension, which one is concentric? The one on the back or the one in the front? Or you could say dorsal and palmar surface.
So the one that's concentric is the posterior forearm, right?
Yeah.
And then the
is that
eccentric will be
extensor or the flexor?
it'll be the flexor.
Yeah, that's right. So the eccentric is the flexor and the extensor is the concentric. Eccentric is the flexor. Yeah. Okay. So for the structure of the muscles in the posterior compartment of the lower leg, the one that we see usually from looking at the back that are highly visible are the gastrocnemius muscles, right? Gastrocnemius muscle. If you cut that off and look underneath, there's a big muscle underneath, and that's the soleus muscle. Very, very strong ankle flexor, ankle plantar flexor. And as the evening goes on, I have to slow down a little bit with what I'm saying. Are you clear about the soleus and the gastrocnemius chardae? Great. Is this large enough, this thing? Josh, you doing all right? Good. During the contraction of a skeletal muscle, which of the following actions occurs immediately after the brain receives impulses? Is the acetylcholine released? Is the motor unit stimulated? Is the muscle fibers stimulated to release calcium, or does the contraction occur? So contraction of a skeletal muscle immediately after the brain receives impulses, immediately after the brain receives impulses. And the answer is the motor unit is stimulated. Okay, this is a good read. I also have a nice video on this in your notes. The motor unit is a group of muscle fibers that are all innervated by a single neuron. When the brain receives an impulse, it sends a message to the neuron, which in turn stimulates the motor unit. When the motor unit is stimulated, it releases acetylcholine. After acetylcholine is released, the muscle fiber is stimulated to release calcium. I would say after acetylcholine is released, the muscle fiber releases or dumps calcium. The actual muscle contraction occurs after the release of calcium. Okay, let's close those. Oh, this one is labeled in your, this is labeled Kinesiology 10 AMTA app. So it's the 10 kinesiology questions I pulled out of the AMTA app. Where's that video? That I just mentioned. Ego Prep, MBLEx handbook, joint movements. I think it's on this playlist. Playlist. Okay, I'll have to find it for you. All right. Okay, AMP1 in your notebook, in your Google Drive, your MBLEx Drive, AMP1. In anatomical position, which bone of the forearm is medial? Which bone of the forearm is medial in anatomical position? It's the ulna that's medial. All the rotators of the vertebral column work together. If all, wait a minute. The question is not grammatically correct. If all the rotators of the vertebral column work together unilaterally, what are they? Or all the rotators of the vertebral column working together unilaterally, what are they? Iliocostalis, picture the muscle in your mind. Iliocostalis, rotators, external and internal obliques. Latissimus dorsi, rotators, external and internal obliques. Multifidi, rotators, external and internal obliques. Rotators and multifidi, spinalis, longissimus, and iliocostalis. Okay, I'm going to tell you guys and then show you guys a couple short video clips so you can see movement. But the answer is multifidi, rotatores, external and internal obliques. Raise your hand if you got it right. Excellent. Because there is room to learn something. So the multifidi and the rotatores are basically the same structure. They're just in slightly different places. So these are the multifidus muscles. And these are the rotatores, or the rotators, right? See how similar they are? Okay, so the rotators or rotatores muscles, you can imagine that they would do some rotation, but that's not the only thing that they do. The multifidus and the rotatores, they also do extension of the spine, and they do rotation, they do side flexion to the same side, and they do rotation toward the opposite side. So the right rotatores and multifidus in your neck rotates the head toward, or the face toward the left side, for example. And it side flexes toward the same side, right? Same in the thoracic spine. If you were to turn like your right shoulder toward the left, that would be the right multifidus and right rotatores. Likewise, if you were to extend, that would be the rotatores and the multifidus muscles. If you look at the attachments of the rotators, it makes a little bit more sense to me to look at the attachments. So these things go 3 vertebrae at a time. So let's say that here's a vertebrae. Let's call this T7. All right, and there's the transverse process of the T7. Here's the right one, here's the left one, here's the spinous process, right? And here's one of the multifidus muscles. T7, T6, which it skips, and then T5, which it attaches to. So here's the transverse process of T7. Here's T7. It passes over T6 and attaches to part of the spinous process of T5. So it's going to pull this bone, this muscle is going to pull this bone down in a side flexion movement. And it also would help to rotate toward the opposite side. So let me just make sure I'm telling you correctly about the rotation. So multifidus rotation contralateral. Let's see. Bilateral contraction of multifidus produces extension. Just this way. The vertebral column at all levels, when the muscles contract unilaterally, they produce ipsilateral, same side lateral flexion. Right multifidus brings side flexes the neck to the right, and contralateral rotation of the vertebral column. So that's toward the left. So the right multifidus rotates it toward the left. Contralateral rotation of the vertebral column.
Hey, excuse me, Kim, what does unilaterally look like? Like, how do we do that?
Yes. So unilateral. So imagine the multifidus muscles running like this. Okay. So if the multifidus muscles contract on bilaterally on both sides, there's extension. There's extension. If they contract on only one side, like on this right side, then you get either side flexion on the same side, or you get rotation toward the opposite side. Probably that looks a little bit more like this. So it's the right side contracting, turning the spine toward the left. Does that make sense?
Yeah, so unilaterally is kind of like just going off to the side, sort of say, right?
Unilateral is one side of the body off the midline. So
Okay.
the right side is unilateral, the left side is unilateral, both sides are bilateral. Okay.
Perfect.
So now, and then the obliques, the internal and external obliques, the way I remember those is that the external obliques make an X and the internal obliques make like an A, right? So internal obliques can be they can be confusing. However, if you just look at the sternum, if you start at the sternum and the midline in the front and follow the fibers, this is clearly an A, right? It's making an A. And the external obliques, why is there no good photo of the external obliques? The external obliques, okay, this is not showing the fibers very clearly, but the fibers are going this way. They're pointed down. And if you follow them, it makes an X for external. X for external. Perhaps that's not the best analogy because you could make an X out of the internal obliques as well. I will look for a better way. See, if I just go this way across the midline, I'm drawing an X. I'll look for a better way to differentiate and remember those. Like your mnemonic devices are really important. Let's see, internal and external. External rotates you. Ipsilateral. Internal ipsilateral. Well, let's take a look at this video. I think the internal does ipsilateral. So I'm not going to make you guys watch a whole 2-minute video.
Hello students, we're going to discuss internal and external abdominal oblique and how they contribute to rotation of the spine. Now the more posterior fibers are fairly vertical, they can contribute to lateral flexion and some extension, but probably not much rotation, certainly not for neutral. And some of the more inferior fibers are also not great at rotation. But the more superior anterior fibers of both internal and external obliques are efficient at rotation. So I've represented some of the sections here. In red, this would represent external oblique, and in yellow, internal side muscle is external. Here, internal oblique.
Oh, he's not going to show the movement. Okay, yeah, there it is. Okay, so here's the midline. You see this white stripe here? How do I increase? This is the midline. Make sure my brightness is all the way up. And here's the midline. And the external obliques go from the midline upward. Right? And the internal obliques go from the midline downward. So there's a way that you could remember it. From the midline down and from the midline up for external. So if you look at this shoulder, this is the right shoulder. The right shoulder is going to be pulling down toward the left hip. So when he does that rotational movement through the skeleton, it's the external oblique that's doing same side flexion, right? It's doing a opposite side flexion, contralateral flexion. So it's bringing the right shoulder toward the left hip. Right to left is contralateral, opposite side, right? The internal oblique is being said to bring the midline toward the left hip, which would be considered ipsilateral movement. So that's a way that you could remember it. Internal ipsilateral, internal letter I. External, the external oblique does contralateral, the internal oblique does ipsilateral. How do you guys feel about that? Okay.
Can you say it one more time just so I could write it down?
Yeah, of course. The external oblique does contralateral rotation. The internal oblique does ipsilateral, IPS, E-L-A-T-E-R-A-L, ipsilateral. Yeah. Raise your hand if you need me to repeat that. Raise your hand if you need me to repeat that. Okay, great. You just kill the sound on this and you can watch a little bit of the movement. Yeah, when used together, both sides, they also can do some amount of flexion. So there's not just rotation. There's also some flexion, right? So that's like a wood chopping movement or a yeah, that's good enough. Whoa, hello, bodybuilder. Bye-bye. Don't worry, the human form does not embarrass me. Okay, now this is a pretty good, yeah, so this is showing the external obliques. So remember, external would bring the shoulder contralaterally, right? It does contralateral rotation. So let's see what this looks like, right? So here it's the left shoulder rotating toward the right hip. So it's going this way, right? And there's also side flexion on the same side, flexion on the same side. That's the rectus abdominis. Just a minute, please. Yeah, that's the external oblique. This also is the external oblique, starts on the midline and goes upward. And this is the internal oblique starting on the midline and going downward. starting on the midline and going downward. External starts in the midline and goes upward. The internal oblique is rotating. The internal oblique on the right is rotating the body around toward the right. Internal oblique on the right is doing ipsilateral movement, rotating the body around toward the right. The external oblique on the left is rotating the body around toward the right. The external oblique on the left is rotating the body contralaterally. External oblique contralateral, internal oblique ipsilateral. External oblique contralateral, internal oblique ipsilateral. Repetition is the mother of learning. Okay, now let's go back to the question. I'll give you guys a minute to finish writing. Let me know if I can repeat anything for you. Okay, holler if you need me to repeat anything. We're going to go back to the question now. All the rotators, if all the rotators of the vertebral column work together unilaterally, what are they? That's the multifidi and the rotatores, which you remember do side flexion on the same side ipsilateral, and they do contralateral rotation, rotation toward the opposite side. External and internal obliques. External starts on the midline and goes up. Internal obliques start on the midline and go down. Okay, the spinalis muscles, you may or may not know, it's not the spinalis muscles which do extension, the longissimus and the iliocostalis. I believe those may do flexion. Those are like the deepest flexors of the neck. Latissimus dorsi attaches to the vertebral column, but its action is not going to be, it's not a rotator of the vertebral column. It acts on the arm, and it does act on the shoulder blade and the hip. And then iliocostalis is up here. Iliocostalis is not one of them. Okay, moving on. Of the following groups, which is in charge of abduction and adduction? I'm sorry. Of the following groups, which is in charge of abduction, abduction, and adduction, adduction? Is it, okay, the answer is just right there, yeah. It's the extensor carpi radialis longus and brevis. And for adduction, it's the extensor carpi ulnaris and flexor carpi ulnaris. And then the other choices, look at them, are palmaris longus for abduction, adduction, extensor carpi ulnaris, and flexor carpi ulnaris. Abduction, extensor carpi radialis longus. I'm not going to read them all. Now, how many people, let's see a show of hands, for those who would take one look at this and be like, OMG, I have no idea. I would totally be like that, right? So you have to look at the surfaces on which the muscles are situated. So of the following groups, which is in charge of abduction and adduction of the radiocarpal joint? So you have to find the radiocarpal joint, radiocarpal, ulnocarpal. So it's this one. So it's, remember, the anatomical correct position is like this. You should be in the test going like this. They should be looking at you like, what? So this is abduction and adduction of the radiocarpal joint. So that would be this way and this way. So this would be adduction and this would be abduction. So you're looking for the muscles that are over here for abduction, over here. And feel free to touch and feel which muscles are moving. It's these on the radial side. It's not these on the ulnar side. And when you adduct, it's these on the ulnar side and not these on the radial side. It's not the palmaris longus or opponens palmaris or palmaris longus or whatever muscles are in there. Let's look at this one down here. Extensor carpi radialis longus, that could be because extensor, no, actually it couldn't be because it's not the extensor carpi longus, it's the extensor carpi brevis. Oh, I see, they have longus and brevis there. So it could be one of those. And then adduction, extensor digitorum They could be the extensor digitorum muscle, because that one would be involved in this movement. You can feel it. Put your hand like right in the middle of your forearm, find the elbow and go up a little bit. And there's the extensor digitorum. And then go like that. You feel it moving. It's actually moving with both of them. But it's not the biceps brachii. So extensor carpi radialis longus, you don't have to know all of these muscles. You have to know where basically they are. It's the extensor and the carpi that give it away. Extensor and carpi. So extensor should tell you it's on the extensor side, the dorsal side of the forearm. This is the extensor side. This is the flexor side. So it's on the extensor side, and it's on the radialis. I said it's extensor and carpi that gives it away. It's not. It's extensor radialis. Extensor radialis. Extensor toward the radial side. Extensor toward the radial side. Longus and brevis. Extensor ulnaris. Extensor ulnaris. Extensor ulnaris. And flexor carpi ulnaris. Flexor carpi ulnaris. Flexor ulnaris. Flexor ulnaris. Extensor ulnaris. Ulnar side extensor. Ulnar side flexor. Radial side extensor. Radial side flexor. Radial side extensor. Radial side flexor. Questions like these are just meant to like make you panic. Don't panic. Find the surfaces. Like know that this is in the palm. The palmaris is going to be palmaris longus. Yeah, this is in the palm. Know that the brachii is going to be near the I forget even why the bone is called. The brachius is the humerus. The brachius is the humerus. I don't know why it's called that. I should look that up. A person in the blank position is lying face up. Hopefully you know that's supine. This one we're going to skip for next time. We're going to skip that one. The attachment for the wrist and the hand flexors is located on what side of the olecranon process? The olecranon is in the elbow. The attachment for the wrist and the hand flexors. Flexion is this way. Flexion is this way. The attachment is on which side? Place your hand around and feel. Is that on the proximal or distal? Well, it's the olecranon process. Proximal or distal? It's kind of like the distal, but it's more importantly, it's the medial versus the lateral. If I turn my hand this way into the anatomically correct position, it's the medial versus the lateral. Okay, that's all the time. That's all that we have time for tonight. We'll pick it up with this one next time with some of the more specific stuff or some of the other stuff we didn't cover tonight.
So
And
the
then-
correct answer for that one was the medial, right, Kim? Just to get it out of my head. Okay, perfect, guys. All right, cool.
Sorry.
All right, cool,
No,
cool.
thank
No,
you,
it's all right.
thank you. I missed the detail.
Right.
And we got to go over like some of the legal and ethical stuff on a regular basis. We have to do it. People miss those questions. They're an important part of the MBLEx.
Mhm.
Thanks for your patience from last week and this week. And let me know if you have any questions or any any suggestions on things I can do better between now and then. Go ahead and text me with those.
Thank you,
All right.
Kim. Yeah.
You're
Thank you so
welcome.
much. Have a good night.
Yes, you're welcome. Have a good night.